Here I am, I0, and we have got what we've got here, right here, is we've got a live Q&A with plastic surgeon JJ Stoiano, yours truly, live 7 p.m. And if you've got anything to comment about or share, then please comment and share, because that'd be great, very much appreciated. How's the camera angle? How many angles? It's top of my head off there. Evening, Angela. Nice to see you. Yeah, right. I've got some questions, and I've got them on a list which I have prepared, because that's the kind of guy I am. I prepare stuff, and this is the number one question here. We've got a list of 8 questions. We had 17 once a couple of weeks ago. 17. I thought 17 this week, 20, 30, and then the following week I think that was about 5. Anyway, quality, not quantity, and these are quality questions. So mustn't grumble, and I'm not grumbling. I'm very grateful for every question. And this is a question. Where's the specific question? Because it was stuff about hormones and things. It was a good question. It was basically, this patient has said, I've heard the causes of gynecomastia are steroids and marijuana, which is 2 causes of gynecomastia, which I think he was saying he didn't do those things. So he was worried that if it was a hormonal imbalance, if the hormonal imbalance wasn't treated, then will it come back? That was the question. So here we go. Here it is. If the issue is hormone imbalance, which I'm led to believe it is, considering it's not marijuana or steroids, is there not then the possibility of developing gyno once again? So yes, there is. And the thing about gynecomastia is, yeah, it absolutely depends on the cause, and steroids and what have you, like especially like steroids for bodybuilders can do it. And basically it is a hormone imbalance, and there are certain things that can cause a hormone imbalance, like certain drugs, like the ones we mentioned, but also ones that are treated certain cancers. Also, there are certain tumors that can cause it. So testicular tumors, pituitary tumors, tumors with the adrenal gland, liver tumors. There's certain tumors which can produce hormones and cause an imbalance between the estrogen and the testosterone, which can cause gynecomastia. Also, certain times of life, there are hormone imbalance, particularly during puberty and in senility, as in older age. You get an imbalance between the estrogen and testosterone, and you can have too much breast tissue growth. So these are all the causes of gynecomastia. And if you have an underlying cause of gynecomastia, you need to treat the underlying cause of the gynecomastia. And so if it's happening during puberty, then you would say, well, let's wait till puberty's over with and see if it gets better. If it's due to some medication you're on or some drugs you're taking, if you can stop that medication and those drugs, then it will be that's the right thing to do first. If it's due to a tumor, then you need to get that sorted first to stop the hormone imbalance, because you're absolutely right, it will come back in. The problem is that the majority of cases are what we call idiopathic. So whilst there's a huge list of causes of gynecomastia, the majority of cases are idiopathic, which means we don't know the cause, which means there is no underlying cause. And so the majority of cases are no underlying cause. So if you're worried you've got an underlying cause, if you have symptoms, if you have symptoms of any of these cancers, testicular cancer, pituitary cancer, they all have symptoms associated with them, then that needs to be investigated to see if there's an underlying cancer. Similarly, if breast cancer can cause increased growth of one side, but it's usually one side, it's usually hard, it can often be painful. So if there's any worrying features, you get that looked at and treated. But the majority of cases are idiopathic, have got no cause. And if it's idiopathic, then you can treat it because there's no underlying cause to treat. So that's why if bodybuilders are still taking steroids, I say there's no point in having gynecomastia treatment, because it'll come back again. So if it's idiopathic, then you treat it with by removing the glandular tissue and the fatty tissue. The only thing I would say is that sometimes people say it's come back if they put on weight. You take all the gland away and all the fatty tissue away, while you leave a little bit behind the nipple, because otherwise you get a crater deformity, you get a dent. But anyway, take it all away, but you do leave some fat behind. There will still be some fat there. So if your weight changes, particularly if you put on weight, that fat will get bigger. The whole thing about putting on weight, you've got the same amount of fat. Everyone's got the same amount of fat cells. Fat people have just got bigger fat cells than thin people. So the fat cells get bigger when you get fat and smaller when you get slim. So you will still leave some fat cells there. And so that those fat cells can get bigger. So if you put on weight, then it can come back again, sort of thing. And they think people say it's coming back again. It's not coming back again. It's just you put on weight and you're getting fatter. So if you hadn't had the gynecomastia correction, you would have got bigger as well. So it's not a recurrence of the gynecomastia. It's not like, oh, there's an underlying cause, it's all coming back. It's you put on weight and the fat's got bigger. So that's the only other thing. So headline question, can it come back after having surgery? If there's an underlying cause, yes. The majority of cases don't have an underlying cause. And if you put on weight afterwards, then it can get bigger. It's not it coming back, it's just you're putting on weight, but you've been reset to a better position. I think we've got that one there. Zoe, Karen, and Junie is in the house, so big up yourselves, and nice to see you all here tonight. If you've got any questions, fire away. I will do my best to attempt to answer them. I've got some preordained questions which I will talk about here. Question numero dos: can I wear a bra straight after having inverted nipple correction? Oh, I've got to get back to my list of questions here. Multi-screening, that's what I'm talking about. It's totally professional, this. Yeah, you can wear a bra straight after having it in. Bras, you've got to think about why you're doing why bras are sort of, what bras are doing. Oh god, making no sense, man. So basically, if you're having a breast augmentation or breast reduction or some kind of breast reshaping, should we say, operation, breast lift, the bra is giving support. So the bras are, we use sort of post-op bras, but like it's sort of like a sports bra. And what you'll find, these bras don't have much shape to them. They're sort of flat when you look at them, and when you put them on, they sort of give you, I wouldn't say compression, you don't really want to compress, but you give you support. So that's like a support bra. So that's the sort of bra you use after a breast augmentation or a breast reshaping in terms of lifts or reductions and things like that. After inverted nipple, you don't need that sort of bra. So you don't need a post-op bra. In fact, a post-op bra is bad. So you don't need a post-op bra after having an inverted nipple correction. An inverted nipple correction is you make the nipple obviously from being sticking in to pull it to going out, and it's quite easy to do, to make the nipple stick out. The problem with an inverted nipple correction is always recurrence of the inversion. So the scar tissue pulls the nipple back in again, and it goes back in again. That's always the problem. So you need to avoid pressure on the nipple. So we put a little bolster around it, a little dressing on top, but you don't want any pressure on the nipple. The sort of traditional post-op bras do give pressure on the nipple, and then sort of will squeeze it. So you don't want a post-op bra. You don't want one of those bras where you can actually see the nipple, you know, when it's sort of, as I say, it's got no substance to the bra and it sort of contours to the shape of your breast. Don't want that sort of bra. You want a normal bra, like a normal, like wires and all that. You can wear wired bras and all that sort of thing. You know, we always go against wired bras when we do surgery because there's often scars in the crease, and often the bra doesn't give much support because the support comes from the wire. So, you know, those bras are, so it's a different type of bra after inverted nipple. The normal traditional wired bra with a sort of shaped cup, rubbish after most breast surgery, but after an inverted nipple, absolutely fine, perfect. If it's got a shaped cup and there's sort of space in front of the nipple, absolutely fine. Or if it's flimsy and it's sort of, you know, sort of fashionable sort of thing with a wire and not much substance to the cup, absolutely fine after an inverted nipple, because you don't want pressure on the nipple. So yes, absolutely fine to wear a bra straight after having an inverted nipple correction, and just wear a normal bra, not a sports bra or a post-op bra. In fact, a sports bra slash post-op bra would actually be a bad thing to wear. So just go with a normal bra or no bra. You don't have to wear a bra. So it's not, you know, if you don't want to wear a bra, don't wear a bra. So can I wear a bra? Yeah, you can, but you don't have to. A bra is basically not important after an inverted nipple, as long as you're not wearing the wrong type, as previously mentioned. So, good. Question 3. Now I'm going to take my time because I'm on question 3. I've got 8 questions. Okay, so no, just get it. But if you've got, you know, if you want a question, you can ask. You know, 8 questions not bad. Did I say 7? I had 7. I just got another one earlier on, so that's good. Have I got a question here? Have you seen what? Did you see me do something to my screen then? Can you see my screen? It's a bit awkward if you can. Inbox, got something in the inbox. Anyway, I don't know. Can you see my screen, or did I just stay on screen all at that time? So, question 3 is: would hair need to be shaved if a cyst was to be removed from the top of the head? Good question. Am I? Oh my God, am I seeing myself? Oh, I'm gonna have to close that. That's awkward. Good question. Good question. Yes. Well, no. Right. It's always difficult, this, because it depends on who's doing it. Good question. Bad answer. Depends on who's doing it. So some people will shave a bit of hair from around it. I tend not to really shave much hair from around it. It's a nuisance when you're suturing something on the scalp, because the hairs get in the way and they get caught in the stitches and you have to pull the hairs out. So some people do shave a bit of hair, but I think that's not, well, that might be what you're talking about. You wouldn't shave it like a big bald patch, especially on a lady with like long hair and stuff. You wouldn't, but you might trim a little bit of hair just because it keeps on getting caught in the stitches, but that hair will grow back. And you would aim, if it is someone with long hair, that it would look normal. You wouldn't like have a bald patch over your scalp. That would be not good. That would not be cool. So we just wouldn't do that. No, we wouldn't shave a big area, but might trim a little bit of hair. The main thing about when you're taking a cyst off the scalp is that the hair, the scar hasn't got hair. You get something called scar alopecia. The scar doesn't have hair in it. So the scar itself won't have hair in it, but there will be hair on either side of the scar. So if you've got long hair, if you're female with long hair, it'll be fine because you have hair over the scar and it'll cover it. The main problem comes in men with short hair or thinning hair, because we just actually this is why the question is there. I saw a photo of a chap with a cyst on his scalp here, and his hair is thinning. And I'm thinking, hold on a minute, his hair is thinning. Now, obviously, you can say, well, I can see the cyst, so I don't like it because there's a big bump there. Fair enough, we can remove the cyst for you. But the scar will be more obvious in someone with short hair, a bit like when you have a stubble. So if you have a scar on your chin, and it fades and all that, and you clean shaved, no problem at all. If you grow a bit of stubble, all of a sudden the scar becomes very well outlined, because when you've got short hair, you've got no hair on the scar, and it's a bit more obvious. Same with the scalp. As I say, if they've got no hair, a scalp can be like, if you're bald, like proper shaved and buffed, the scar will probably be pretty good. A bit obvious to start off with. But when you've got a short bit of hair, the scar is more obvious because you get no hair on the scar, so it's more obvious in a short hair person. It's better if you've got nothing at all and you're totally bald, or if you've got long hair. Either extreme's good, but short hair is bad. Who knew? Can you go on an aeroplane? I think that's it. A week after breast surgery. A week after? I didn't read that. I didn't see that. A week. Well, you can if you want to. Would you want to go a week after breast surgery? I'm not sure if that's. I wouldn't particularly recommend going a week after breast surgery. I think that's a bit too soon, to be honest with you. There's no sort of physical restriction to it, so you're not going to set off any alarms. They're not going to blow up on the aeroplane. People think they're going to pressure the aeroplane, they're going to explode or things like that. The aeroplane cabin is pressurized, and the pressure to damage an implant would be so extreme, your internal organs would be damaged way before your implant will be damaged. Similarly with diving, people talk about diving and the pressure and stuff. If there's any problems with the pressure, it's the pressure in the air in the pocket rather than the implant itself, which is there immediately after surgery. But there aren't any problems with flying. So you can get on an aeroplane and fly a week after surgery, no problem. Nothing's going to happen to you. No alarm's going to go off. I wouldn't recommend it though, because you just had breast. Oh, actually, it doesn't say implant, does it? It just says breast surgery. Your scars will be a bit red. You're in the healing phase. You may or not. You're just, the skin takes about 4 days to heal. So your skin may be healed by then, but there might be little bits of the skin aren't healed. Depends on what breast surgery is. Well, actually, it doesn't depend on what breast surgery is. I think any breast surgery, I probably think a week is too. Well, I do think, not probably. I think a week is too soon to go on a flight for two reasons. Number one reason is that even though you think, oh, I'm just going to relax when I go away, it is quite stressful going on a flight. You've got to carry bags and things like that. You might say, oh, I won't carry heavy bags. It is a big deal. It's a lot more than staying at home. It's like when people say, I want to go to work because I don't do anything at work. I just do office job. It's quite a big deal to go back to work. So don't underestimate it. So I think that's number one reason. Number two reason is that you'll be away from home. So if you have any redness, if you have any problems, I'll say to you, give us a ring and come back to clinic. You'll be like, well, I'm in Marbella. That's a big deal. So, and it's just a nuisance. If I say, oh, that looks a bit red, give you some antibiotics. Oh, well, I'm in, Guadalajara or wherever, maybe a little bit more difficult to get antibiotics. So it's a lot easier to stay at home. So I would stay at home 6 weeks, 8 weeks minimum. You'll probably still be a bit sore and might not be able to carry your bags, but at least you're out of the woods with regards to wound healing problems, infections and stuff like that. So as I say, you can fly if you have to, but I probably wouldn't particularly recommend it. In fact, I definitely wouldn't recommend it a week after surgery. I think that's too soon. But make your own judgment and see. I'm not sure who that was from, or if it was from my patient, but yeah, I think not a bit too soon, a week. It's a big deal having surgery. You've got to not underestimate it. A week to fly a week afterwards. I think that's too soon. It's a big deal. It's a major life event. So most breast surgeries, anyway. So don't underestimate it. It's a good one. Would excess pubic fat be removed or improved if a tummy tuck is performed? Good question. I'm liking that one. People don't often realise this. The pubic fat, we call it the mons. It's the sort of area where the pubic hair is. So it's sort of, if you've got a cesarean, below the cesarean scar, that sort of bulge there. People often don't realise they've got a bulge there, particularly if you need a tummy tuck. So they've got a big abdominal apron and they don't realise there's fullness of the mons. So what you do is you do the tummy tuck and they think, what the heck have you done there? What have you put that? What's going on? I'm like, well, that was there already. I just got rid of the abdominal thing and there's a bulge that was there. I just found it there. So you can do stuff to that mons at the time of a tummy tuck. You can reduce it. You can perform liposuction. If it's very big, you can liposuck it. And you can reduce it and take out the fullness. You don't want to go too crazy on it, because what you don't want to do is go too much. When you do a tummy tuck, you make a scar here, and a scar in the lower abdomen, and a scar in the upper abdomen, and you undermine all the way up to your rib cage, so that the scar in the upper abdomen pulls down and meets the scar in the lower abdomen, so the scar ends up in the lower part of your tummy. I'm not sure if this is, maybe need some infographics to explain this, but you want the scar to be pulled down and to be in the position of the lower incision, so it's hidden in your bikini line. You don't want it to be up here, and the reason the scar is low is because you undermine in a northward direction, so that the bit up north is movable and will move down, and the lower bit doesn't. You don't undermine the lower bit, you just leave that in place so it doesn't move much to anchor the scar low. That makes sense. If you start undermining the lower bit south, where the mons is, that will loosen that up, and there's a risk the scar can migrate up north, so that is not good, particularly if the hair-bearing skin starts migrating up north. You can get a clitoral lift, which can be uncomfortable, and you can get all sorts of problems which you don't want. So it's a bit of a thing that you've got to be a little bit careful about messing about with with that sort of mons area. You don't really want to go too crazy on that mons area. You really want to focus on the tummy tuck. As I say, there is stuff you can do to the mons. So you can take a wedge out, do a bit of lipo, you can improve it. But if you've got a significant fullness of the mons, it's always better to have this conversation before surgery. And what we'll try and do is point it out to you before surgery and say, look, you've got a lot of fullness in your mons. I'm going to do my best. But when you've had the tummy tuck, you might still see some fullness there. And we might need you to do stuff later on, once everything's healed and the scar's stable where it is, then maybe you can take a little bit from below, but you've got to be a bit careful with it. So it's a great question. Fat can be removed from that area, and it can be improved at the time of a tummy tuck, but we are limited as to how much we can improve it, because there's a whole world of problems you can get if you start trying to go crazy on it and trying to sort of really empty it out and think, oh, I'm going to make this really flat and I'm going to undermine it, and clitoris is pulled up, that's uncomfortable. The hair bearing skin's pulled up, the scar's pulled up, and it's just bad. So a bit of a balance, but something we try and be aware of. So something probably we're aware of more than we maybe will communicate to patients, but it's a good question. It's something that now you've watched this, maybe you'll be a bit more aware of it and think you might ask a question next time if you or have a look and to see if you're thinking of tummy tuck, have I got fullness in that pubic area, and what's going to be happening to that. Tracy's here, staunch supporter. Good to see you, Tracy. How are you? Tracy, we're on question number 6 of 8. Coming to the end game. When to have breast reconstruction after mastectomy? That's a massive question, that, isn't it? That's a massive question. Also, I don't really do breast reconstruction anymore. I used to do loads of breast reconstruction. Well, I can. Well, anyway, I shouldn't say that. Well, I'm trying to. Anyway, it's not about me. It's not about me. All right, get over it. It's a general question, and so I'm going to give you an answer. Really good question. So broadly speaking, you have 2 options. What's called an immediate reconstruction, which means at the same time you have a mastectomy, you have a breast reconstruction, or a delayed reconstruction, which means you have a mastectomy, you have a mastectomy scar, that all heals, you get over that, and you have a reconstruction later. And this is a big question, and probably something that I'm not sure I can do justice to on this. And it's really something you need to discuss with your surgeon or surgeons, because it depends on several things. It depends on you, and it depends on the sort of treatment that you need. So on you, a lot of it is sort of the psychology of it. Sometimes people feel that they like the thought of going down to theatre with a breast and coming back with a breast. Psychologically, that's a appealing thing, obviously. Not sometimes, I guess everybody finds that appealing. So that's a good thing about having an immediate reconstruction. You go to theatre with a breast, you come back from theatre with a breast, albeit a reconstructed breast. So that is a good thing. The bad thing is that when you have a diagnosis of breast cancer, that's quite a major thing, and often you need surgery quite quickly, and psychologically it can be quite a lot to take in. If you then have to start taking in the whole gamut of breast reconstruction, there's so many decisions with breast reconstruction. You think, oh my goodness me, it's all too much. And you might say, look, just do the mastectomy. It's a relatively short operation, get that done, and then I can consider a reconstruction later. Because a mastectomy on its own is a sort of average operation, not that big an operation, but a mastectomy with an immediate reconstruction can be a big operation. So you can turn a sort of medium-sized operation into a big operation at quite a vulnerable time when you're quite psychologically in turmoil because of, you've been given this diagnosis. So you might say, I can't face it at the moment, it's all too much. So you've got to think of it from your point of view, where you're at, whether you want to just come back with a breast and you're well from when you go to theatre, and you're willing to put up with a big operation to achieve that, and also whether you're willing to go through the turmoil and the decision making in terms of breast reconstruction, because there's all sorts of different types and pros and cons of all of them. So there is that. Then there's issues in terms of the disease and the treatment that you need. So it depends on what sort of treatment you need in terms of the mastectomy, and whether you need any what's called adjuvant therapy. Adjuvant therapy is things like radiotherapy and chemotherapy. So, and often they can tell before, sometimes they can't necessarily tell before whether you're going to need it, but often they can tell you before whether you're going to need adjuvant therapy. If you need adjuvant therapy, if you need radiotherapy sort of blasts the area once you've had the mastectomy, or it could be a wide local excision. If you have a wide local excision, you pretty much always need a radiotherapy, and kills any remaining cancer cells that are left behind. Now, if you do an immediate reconstruction where you put the tissue up there at the same time as the mastectomy, when they do the radiotherapy, they're going to blast that that reconstructed tissue. So it can damage your reconstruction in terms of causing some scarring and some abnormalities of shape. Now, there are significant benefits of having an immediate reconstruction, so that might be outweighed by that risk of the radiotherapy being blasted. But some surgeons say, look, if you're having radiotherapy, have a delayed reconstruction, don't have an immediate. I'm not like that. I do think there are benefits of having an immediate reconstruction, particularly if you're going to use your own tissue, something like your tummy tissue. So I think there are benefits to having a reconstruction, but it's true that if you were going to have radiotherapy afterwards, that can damage the reconstruction. To what extent and whether that would mean you need another operation or whatever, it's hard to say, it's hard to quantify. But obviously, if you have a delayed reconstruction, you'll definitely need another operation. So that's what I mean about not being able to answer it properly here. It's really something you need to talk to your breast surgeons and your reconstructive surgeons, or you might be the same person about that. The other bit of adjuvant therapy you might need is chemotherapy. Chemotherapy is sort of drugs to kill any cancer that might be in your body. Radiotherapy is a bit more of a directed treatment. Chemotherapy is more of a systemic thing, and that can be important to remove any cancer that might be in your body. If you have a mastectomy on its own, you just have one scar, and you've got to get that to heal. If you have a mastectomy reconstruction, you often have more than one scar because you might have had a reconstruction from a bit of tissue from your body, and it all might be tight, and there's more risks of wound healing problems, and there's more risk of complications if you're having an immediate reconstruction. And so if you do get a complication, if you do get a wound healing problem or something like that, that might delay your adjuvant therapy, particularly your chemotherapy. It might delay they might not want to give you the adjuvant therapy if you've got wounds that need healing. So you might say, well, that's going to jeopardize my cancer treatment. I need to get this adjuvant therapy. I need to get this chemotherapy to mop up any cancer cells. And if there's a chance that having an immediate reconstruction might delay that, that might factor into your decision making. You might think, hold on a minute, I just want to get the cancer treatment done first, and then next year I'm going to think about reconstruction. It's different things for different people. So that's one reason against having an immediate, that it does make it potential that you might have a delay in your adjuvant therapy. Not necessarily, but more likely than if you just had an immediate reconstruction. Finally, the cosmetics of it. Cosmetically, an immediate reconstruction is far superior to a delayed reconstruction. It does look a lot better. The thing about a delayed reconstruction, if you've got a breast with lots of skin, when they do a mastectomy, they're not really interested in taking the skin. The only skin they're really interested in taking is your nipple and your areola. That's all they really want to take. So when they do a mastectomy, if you're having an immediate reconstruction, what they sometimes do is just make a scar around the nipple and the areola, take that out, and then take the rest of the breast out through that incision. And then when you're doing a reconstruction, you can fill that skin envelope with your breast reconstruction and just use a little skin paddle for that nipple, and then you can reconstruct the nipple. So actually, once you've reconstructed the nipple, it looks like you've got no scars because you only had a circular scar, which is then swallowed up by your areola reconstruction. So cosmetically, all that skin's intact. Your inframammary fold, the fold where your bra sits, is intact. And so cosmetically, it's a lot better to do an immediate reconstruction. With a delayed reconstruction, you can't leave that skin. If you're not putting a reconstruction in, you can't leave that skin hanging there. So you have to cut the skin out. So you end up with a much bigger scar. When you do delayed reconstruction, you end up with a mastectomy scar, which is that oblique scar across your chest. And then when you're doing a reconstruction, you have to reconstruct the inframammary fold because that's gone and you just have a flat chest. And you have to bring much bigger skin paddle in because you have to import skin from somewhere, or you might use implants or what have you, and you have to stretch the skin. But you have to, it's a more difficult reconstruction, and cosmetically it's never as good really a delayed reconstruction as an immediate reconstruction. So tricky one. No answers there. Pros and cons for both of them. Needs a proper discussion with the surgeon or surgeons, but that's some of the issues around immediate and delayed breast reconstruction. But really good question. Really like that. That's a good question. Hi Nikki, good evening. Nice to see you here tonight. Where are we? This is a good one. This is a question that I've been answering a patient, and it's timely because we just spoke about this at the weekend. I went to a meeting at the weekend and this was being discussed. They call it the plus minus technique. So the plus minus technique is having a breast reconstruction and then putting an implant in for the shape. And I'm aware that people do it. But as I say, I was at a meeting, there's a chap presenting from Brazil who was presenting his results of it. Not, you know, I'm not big on it. The concept is that when you do a breast reconstruction or a breast lift, a mastectomy, you're dealing with your own tissues. You're dealing with, you know, your tissues. And when you do a lift or a mastectomy or whatever, I mean, a lift is a mastectomy, a lift or a reduction, you tighten all the skin up and it stays up here and it goes up like that. And people say, oh, I love it. Yeah, happy with this. Exactly what I wanted. Fantastic. Thanks very much. And you're like, well, hey, hold on a minute. You know, you've only just had the surgery. To be honest with you, it looks a bit weird when you first have it, when you have a reduction or a lift. Reduction and a lift are sort of like the same thing. They both involve lifting the breast. Over time, that settles. That fullness in the upper pole, from your nipple up, settles to what I would call a more natural breast shape. And I show photos of people this in the clinic. So you get a softening of that upper pole. So you get like a either straight line or sometimes a concavity in your upper chest from your nipple, you know, to your nipple, and then a fullness in the lower pole. So it empties from the upper pole, goes into the lower pole. That's gravity. That happens to tissues. And as far as I'm concerned, when we spoke about this at the meeting, people do injecting fat and all sorts of things to try and keep the breast up there. And, you know, it's really, you can't, well, as far as I'm concerned, you can't really keep the breast up there. Whatever happens, gravity wins, and you get a bit of a concavity and less fullness in the upper pole. I think it's a, you know, it's a natural breast shape, but, you know, we show photos to patients and then I think, hold on a minute, if I'm having a lift, I want it, you know, I want a bit of this, don't want that, that's why I'm having the lift. I'm like, well, it will be better than you are now, but, you know, it will settle a bit. The only way, in my view, to get sustained fullness in the upper pole, to get either a flatness or even a bump in the upper pole, sometimes people want actually a bump, is with an implant. An implant does give you sustained fullness in the upper pole. Now, for me, I think implants are really good at making your breast bigger. So if you're small and you've got a bit of a droop to your breasts, you don't like the shape, you want to be bigger, you don't like the size, I'm like, yeah, okay, well, let's do a lift and let's put implants in because that makes them bigger, makes the shape better, and you do get that fullness in the upper pole because the implant is there and that will give it. The problem comes when people are happy with the size. They don't want to be bigger, particularly if they want to be smaller. The concept is that you actually take some breast tissue away and you replace it with an implant to give sustained fullness in the upper pole. I don't like that concept. Just, you know, I suppose it's not about me, it's about you and what you want. So, you know, it is a thing and it is out there that people do that. They take a bit of breast tissue away and then they replace it with an implant to give some sustained fullness in the upper pole. The problem I've got with it is the implant will have to be a certain width in order to be a certain height to fill the breast footprint to give you the result you want to achieve. If you put a narrow implant in, it's going to drop to the bottom. It's not going to do the thing that you want it to do. So it's got to be a certain size. Now, this chap from Brazil was presenting cases where he was using quite a small implant. So it's a balance, you know, for that reason. You don't want to take loads of breast tissue away and put a massive implant in, because the problem with implants, you get problems. You can see them, you can feel them, you get rippling, you get capsular contracture in the future, all sorts of problems with implants. So I don't think you should take on implants lightly, and I don't think you should have implants if you don't need them, sort of thing. But if you want fullness up there, they are the best way to do it. But for me, I don't like the concept of doing a reduction and then replacing some, you know, taking over, reducing too much volume and then replacing some with an implant. I think you're better off having your own natural breast tissue, because then for the rest of your life it's yours and that's fine. With an implant, there's potential problems in the future. But it does give you the sustained fullness in the upper pole. It's an interesting thing. It's an interesting concept, plus minus technique, and it's out there. And I guess it's something to discuss again with the surgeon and just see whether you think it's good for you. It depends on whether you'd be happy. The thing is to look at some results to see if you're going to be happy with the shape that you can achieve with an implant or not. And if you're not going to be happy with the shape that you can achieve without an implant, then is it worth taking on the risks of an implant? I guess that's the same for any sort of thing. But that is a thing, and that's a really good question. Very timely as well, because we talk about it. Tracy, I know you wouldn't let me down. Tracy's come out with a question here. Would you, have you, carry out breast augmentation under local anesthetic so the patient can be awake while having the procedure? Tracy, yes. Would I? Yes. Have I? Yes. Yeah. Yes. I wouldn't say it's common, but it's not that uncommon, really, and I think it's becoming more common. I think to be honest, I think we're moving more that way in this country. Tracy, I've done a tummy tuck with someone awake. I've done a mastectomy with someone awake. So it is a thing, and I don't really push it, to be honest with you. But if patients don't want an anesthetic and they're like, or at least a general anesthetic, for whatever reason, it's a good thing. It is a good thing. I think having it under local anesthetic and sedation is a good way to have it. But the patient have to be on board, because it is a little bit uncomfortable. You put in local anesthetic in, oh, I can feel that. Okay, I put a bit more local anesthetic in and things like that. It's done under sedation, so it's not pure local anesthetic. I think sometimes people think they'll be able to give an opinion on the implants. What do you think of them? Are they big enough? Do you want me to put bigger ones in? You're not like talking like you're normal. It's not like pure local anesthetic. It's local anesthetic and sedation, so you are sort of quite sort of drowsy and quite you're not really, you're sort of talking, but it's like not really talking. I wouldn't hold you to anything. I wouldn't say, oh, what do you think of the size or anything like that, because it is, and you often don't remember much of it. So it's not like you might envisage pure local anesthetic. It's local anesthetic and sedation, but it's a very good way to do it, and it's quite established, and it's becoming more established, I think, in this country. In America, I think they do loads of stuff like that. I think we're moving towards that way in this country. We do it in the hospital where we've got facilities for a GA in case it's a bit uncomfortable. We did one a couple of weeks ago, and a little bit uncomfortable for the patient. So we just said, look, you know what, let's just convert to a general anesthetic. So we normally just say, look, if it's a bit uncomfortable for you, we can just convert to a general anesthetic. But, most of the time it's absolutely fine. Occasionally it might be a little bit uncomfortable, and it's easy because an anaesthetist is there administering the sedation. So the price is the same. A lot of people think it's going to be cheaper to do on local sedation, but the anaesthetist is there just the same, takes the same amount of time. To be honest, if anything, it's more work for the anaesthetist than the general anesthetic, but the price is the same. But it is a good thing, and I think and there's lots of things you can do under local anesthetic, not just breast augmentation. Lots of things, most things, in fact, you can do under local anesthetic sedation with the right patient. If the patient's on board, if the patient's not on board, I wouldn't push it. Right, let's do a general, keep it simple. But if the patient's keen, I think you can do a lot. Nikki, I thought he had, yeah, I thought he's dealt with errors. Yes, these comments are true. I don't want to say too much, Nikki, because last week I made out, didn't I, that I dealt with it, but clearly I hadn't, had I? So I think I might have dealt with it, but I'm not going to say too much because you don't know what's going on out there. So I think, I think we're clear. We're clear so far, and we're near the end. So yeah, so far so good. So yeah. So nipple reduction. Oh, I haven't pressed the thing. Nipple reduction, not the areola, the actual nipple. Can you do it? Yeah, you can. So obviously areola. So it's called the nipple areola complex, the NAC, the neck. The nipple is the bit that sticks out in the middle. The areola is the bit around the outside. So obviously the areola can be reduced, the brown bit around the outside, that can be made smaller with the scar around the areola, but the nipple can also be reduced. In fact, it's quite common in men, nipple reduction, because they don't like t-shirts, so the nipple sticks out too much. But you can do it in women as well. Pretty simple, to be honest with you. It's a local anesthetic. The nipple is just like a mountain that sticks up. You just take out a slice of cake, basically, and then fold it down. You usually put the scar in the lower border so you can't see the scar. There is a scar. The scar's at the base of the nipple, the base of the mountain. So to be honest with you, once it settles, you can't really see it. And it's a relatively simple thing to do. And you can also do, like, for instance, we're talking earlier about breast reconstruction. You can do nipple reconstruction by taking a piece of one nipple and putting it on the other side, nipple sharing. So, and obviously that would reduce. It's only good if your other nipple's too big. If you're happy with the other nipple, I wouldn't go messing with it. But if your nipple is too big, it's relatively simple to to reduce the nipple. In fact, it's more simple than doing an areola reduction. So Junie, safe with you? Yes, thank you. I know that. I'm in safe hands. Good to hear. Had it done awake, good option for people who are afraid of general. Was totally comfortable. Home within an hour. Absolutely. There you go. That's what you need. You need real people, personal recommendation. I think, you know what, people who have it done awake are people who have it done awake are yeah, they love it. They are great supporters, and it does tend to be a good thing. But not for everybody. Clearly not for Zoe. So that's all right. You know, I think it is. Now, Junie, you know, what's going on? Honestly, can you make nipples bigger? Yes. I had unnecessary free nipple graft in Poland. One is slight projection, but other is flat. What can be done if anything? Yeah. I don't like free nipple grafts, and obviously you don't like free nipple grafts either now. Free nipple grafts, I think a lot of people, when you're doing a breast reduction, think that the nipple comes off and goes back in again. That's called a free nipple graft. We actually take the nipple off and put it back on again. I don't, some people do it a lot. It's like, you know, whatever. I don't think it's, I prefer not to do it if I can, than keep the nipple attached on a pedicle. Anyway, the problem with free nipple grafts is the sensation's always altered because, you know, the nerves have to connect up, and the nipple often lacks projection. That is the problem, which is what's happened here. It's, you know what, Junie, it's really tricky because yeah, oh dear, worst thing I've ever done going to Poland. It is tricky to do the to give projection to the nipple for two reasons. Number one reason is it's tricky to give projection to the nipple anyway. To make something stick out is hard. Everything wants to go flat. The body wants to scar everything down and pull it down. So when you do an inverted nipple correction, it's hard. But it's even more difficult for this because this isn't an inverted nipple correction. An inverted nipple correction, someone's got the nipple and it's in, and you have to sort of pull it out. In this case, you've lost projection of your nipple, and just try and give projection to the nipple. Now, the problem is when you do nipple reconstruction, when you make a nipple, you can make a nipple, but you make a nipple from the skin around the nipple. And when you do that, if you do that in someone who's already got a nipple and an areola, you will distort the shape of the areola. So what you normally do in someone who's got a cancer is you have nothing. You have just a white patch of skin, and you make a nipple, and then after that, you tattoo the areola as a circle. If you, for whatever reason, have to reconstruct a nipple in someone with an areola, you use that skin of the areola to make the nipple reconstruction, and that can distort the circular shape of the areola. And you could go on and have a tattooing to make the areola round again, but it is a little bit difficult. Or it's also difficult because where you do a nipple reconstruction classically is by doing what's called a flap, which means rearranging the tissue of that skin. If you've had a nipple graft, that skin is grafted skin, so it hasn't got a great blood supply by definition. So you're trying to raise and move around skin that is scar. So it's really hard to do to make a nipple out of a nipple graft. There are other things people have done by injecting something underneath the nipple, fat, just injecting a little bit of fat under the nipple. People have taken, believe it or not, bits of cartilage, bits of the ear, and put it underneath the nipple. People have taken little bits of like bone cement and things like that, putting things underneath the nipple to try and push it up and give it projection. Anytime people have done loads of stuff means there's no really good thing. And I think you said here, God, we've got some kicking off now. I've lost pigmentation, so I've had tattooing. So you know what, Joni? My advice to you, Junie, you know, my advice to you is to have tattooing and maybe get like that the 3D tattooing to try and make it, give a little bit of shadowing and a little bit darker in the center to make it look like it's got projection. I think that is the easiest thing, Junie, for it. I think doing it surgically on a free nipple graft to surgically give projection to the nipple is tough. It's tough. There's no easy answers because it's scar, and you try rearranging the tissue, you mess up the shape of the areola, and because it's scarred, that reconstruction might not work and things. Really tough. I'm really sorry. It's not easy. That it's a really difficult problem, Junie. You might think, oh, they can reconstruct nipples when they do breast cancer, but then we've got like healthy tissue that will reconstruct your nipple on a free nipple graft. Really hard. I haven't got any easy answers for that, Junie. Sorry about that. That's a tough one. Nikki, my belly button has no stalk due to umbilical hernia. It was attached due to very tight stitches. Would it be easier to have taken it away and a new one made rather than rescue it? Nikki, legendary question. That really good question. You know what? Some people just take it off, throw it away, and make a new one when they do an abdominoplasty, a standard abdominoplasty. So my belly button has no stalk due to umbilical hernia. It was attached. Would it be? Does that mean like it was? Sometimes you do something called floating the belly button, which means you cut it at the base of the stalk. Particularly if you're doing something like a mini abdominoplasty where you're not making a scar around the belly button, you can float the belly button. So you cut the stalk to help the skin pull down. I'm not sure, but it still looks normal, but it just sort of moves. I'm not sure what the not has no stalk. It was attached to. The answer is, I mean, belly button's a thing, you know. There's things in plastic surgery, and belly button is a thing about what you do with the belly button, what shape you make the belly button. So the answer, Nikki, is you can always have the belly button reconstructed. You could have the one that you've got reconstructed. You could have the one you got taken off and a new one made. Things can be done to belly buttons to try and make them look better. Would it have been easier to take away a new one made rather than rescue it? Tricky question, that. To be honest, if it was me, I would have probably tried to rescue it. I don't know what, you know, rather than make a new one. But as I say, there are some surgeons out there, really good surgeons who are presenting at the meetings and stuff, who just routinely throw them away and make a new one. So obviously there's all sorts of surgeons in between. So I think other surgeons will have a lower threshold to just throw it away and make a new one. So I don't know if it would have been easier to have made a new one at the time, but I guess we've got to move forward where we are, Nikki. Let's move forward. Let's not think what would have been better at the time. So if you don't like the shape of it, things might be able to be done. If you want, you can email me a photo. I'll have a look at it and give you an opinion if you want, or you can come to clinic, have a chat. Probably won't be with me though. Probably be with Kuram or something, but you know, Kuram will be able to help. Julie, hi. How much time do you need off work after breast reduction? Do people usually get a sick note for recovery without needing to tell nature of the op? So what's the trait, Zoe? So Julie, how much time do you need off work after breast reduction? Do people usually get sick note for recovery without needing to tell employee nature of the op? Good question. Some good ones coming in. Oh, got some good ones. And Tracy's getting in there as well. This is good. Julie, breast reduction, big op of breast reduction. Don't underestimate it. A lot of scarring and stuff like that. General anesthetic in overnight, or taped up. Come back after a week, all the tapes come off. Feel a bit weird. As I say, the volumes up here will settle. I normally say 2 to 3 weeks for driving. Sometimes the insurance company will have a view on how long before you can drive. Sometimes they say it's up to the doctor. If they've got a view, you better do what they say. If they say it's up to the doctor, 2 to 3 weeks is normal. Some people are, 3 is safe. You might be okay at 2. And that means 2 to 3 weeks usually for work, because you normally have to drive to work. But basically, you can start getting back into things, I'd say, after 3 weeks. But nothing too heavy, nothing too crazy. So I normally say light duties or phase return for 3 weeks. So 3 weeks off, 3 weeks light duties. After 6 weeks, you can start lifting, start getting back into things. That's the sort of normal regime for off work. So 3 weeks off, 3 weeks light duties. Yes, you can get a sick note. We just write surgery on the sick note. We have to write something, unfortunately. So we have to write something. But the sick note doesn't say anything about plastic surgery, what have you. It's up to you. Obviously, you need to tell the employer you're going to take time off and you're having, well, you can tell them, it's really, you can do what you want with regards to telling the pet employer. Unfortunately, people do frown upon this sort of surgery, and I get, it's a bit upsetting when people get told that they can't have time off work for this surgery, but they can for other surgery. But anyway, that's another thing, really, how it's perceived and people think it's unnecessary and everything. But that's another one of my pet things, that people think this is unnecessary. But anyway, it's what it is. So I would suggest you're probably better off just saying to them you're having surgery, and it's, whatever you want to tell them. But I think a lot of people think the employees are going to ring me or ring us and say what surgeries you had. They won't do that. And if they do, we can't tell them unless we will say, well, we've got to ask Julie, and Julie, oh, can we tell your employer? You say no, and you will say, okay, fine. We can't tell them. It's all confidential and everything. But they never do ring as well. People think they ring. They never do ring. So yeah, you can get a sick note, and you don't have to tell the nature of the op to the employer, the nature of the op. Zoe Fisher, for me, it was the best thing. Didn't get to look at the sizing. No, you wouldn't have, Tracy. You just, but was just happy to have it done awake. And actually, Jonathan, no sedation, just local. Yeah, it wasn't just local. You would have been sedated. You may not have felt like you were sedated, but there would have been a bit of sedation there. But anyway, don't want to rock the boat for positivity. Let's keep the positivity coming. Keep it coming. Tracy, good. I'll pay you later. Nikki, I had a hernia op when they sewed me up too tightly. I kept a bursting belly button with infection attached, maybe under pressure. Yeah, no holes, just okay. Yeah, absolutely, Nikki. So yeah, unfortunately, you can get wound healing problems after a tummy tuck anyway, and the areas you get the wound healing problems essentially and around the belly button. The belly button's a naturally sort of dirty area, if you like, because it's like that sort of, we try and clean it and what have you. And particularly if you had a hernia there, it might have been contaminated because if it was open to the abdominal cavity, so you have got a risk of infection there, and that is a thing that's not well. I say it's not uncommon. It's a thing, and so you've lost your belly button, so that can happen. And now the hole is just flat. Yeah, but having an abdominoplasty, so you get a new one done. Absolutely, that's the spirit. So when you have an abdominoplasty, you'll have a new one made. So yeah, that's fine. So you will. That sounds. You've been through it a bit there, Nikki. Or you can have a new one made anyway without having an abdominoplasty. But if you're having an abdominoplasty anyway, then the thing to do would be get a new one made at that time. That's good, wasn't it? At the end, came good at the end. Nikki, Tracy, Julie, Junie got in there. Zoe put her all in. So thank you all for that. That's good. Started on time-ish, and you finish at a reasonable time then. Next week, what's happening next week? Yeah. Next week, yeah, up for next week. So please, any questions, please ask. Email me, Facebook me, Twitter me, do whatever you want. Nikki, keeping it busy. It's the only way to be. 8 quality questions tonight, plus a plethora of questions from the audience. Thank you all for asking questions tonight. I'm very grateful to you, and also grateful to you for watching. If you didn't ask a question, grateful for everything, grateful for the support in any way. I'll take what I can get. I'm going to check myself out of here, and I will see you same time, same place, Tuesday, 7 o'clock next week for another episode. And look forward to seeing them. Bye.